Good morning, everybody. Thank you for HC&I inviting me to come along today. Very much appreciated. I'll make a start because I know we're a little bit behind, but we are catching up with some time. So, as Ken said, I'm Principal Medical Advisor in HCGB. I work in the Health and Work branch of the Engagement and Policy Division. But I do have quite a wide-reaching role. I'm also an inspector in HC, so I do get involved in providing specialist advice to investigations. So today I'm going to talk about health surveillance. The first part of my talk is really going to be related to health surveillance in general. I appreciate this topic of discussion today is welding fume, but there's some broader principles that I wanted to share with you as part of my talk today. And then I'll talk a little bit about in detail about respiratory health surveillance in respect of welding fume exposures. So you're probably already aware of this, but I really just wanted to start by saying what occupational health is. So on the left-hand side, you've got some people doing some work, and the symbols on the right are there to represent various aspects of health. So you've got mental health, respiratory health, musculoskeletal health, and so on and so forth. And what occupational health looks at as a speciality is the interaction between health of the individual and the workplace, and the effect of that workplace on the individual's health. So in terms of this discussion we're going to be having today around health surveillance, we're very much thinking about the effect of the work, in this case welding fumes or welding exposures, on an individual's health, and how we look to identify health conditions as a result of those particular exposures. So the first thing I want to talk about in terms of where health surveillance fits into the scheme of things, and I've made a reference there to HSG 65 in the bottom right, and it's the probably familiar phrase of plan, do, check, act in terms of approach to managing risks in the workplace. But what we've got there is a pyramid of red for the bottom two tiers, blue for the middle two tiers, and then green at the top. And really what this is trying to articulate is you need to get your compliance with the regulations right to form the solid base of the pyramid, because that ultimately protects your workers and ensures they're not being harmed by the workplace. And if they are developing ill health conditions that relate to the workplace through health surveillance, they are picked up early so they can be managed. So you've got legislation at the bottom, which is obviously fundamentally stems from the Health and Safety at Work Act. You've got risk management, and that's articulated in various different regulations, the management regs, COSH, and so on. That overlaps with fitness to work, and the reason why there is that little arrow that's pointing upwards towards fitness to work is some activities do have a safety critical element, and as part of your risk management strategy, you will need to think about whether somebody is medically fit to undertake a particular task. So good examples are confined space working. Is somebody fit to go into that sort of space if they're using forklift trucks, and so on and so forth. So it's really thinking about how health issues that the individual brings into the workplace may impact upon their health and safety in terms of working in that environment. Then above that we've got the should, so fitness work generally, and sickness absence management, and then well-being as could at the top. Now, this is not to suggest that any activities relating to well-being aren't helpful or important, but what we do see in some employers is they get this pyramid the wrong way up. So they spend a lot of time and effort thinking about well-being activities and actually don't address basic compliance with health and safety regulations, and therefore protecting their workers in the workplace. So I just think it's quite a nice way of articulating quite a complex framework of thinking and what you need to get from your occupational health providers in the context of health surveillance. So you do get what you need when you need it, and you address things. If you are prioritising in terms of your risk management, you do that in the right order. So the next part of the talk today is really to talk about health surveillance and its importance. So we really need to define what it is in the first place. So it's a scheme of repeated health checks used to identify work-related ill health. So there's two parts to that statement. One is it's a health check, which is directed towards looking for a work-related ill health activity, work-related ill health from a workplace activity, but it's also repeated, so it's not a one-off. So it carries on over a period of time, usually over the period at the time that the person's exposed, so you get serial results as a result of the health surveillance process. And it's still required when workers remain exposed to health risks even after controls are put in place. Sometimes people are of the view that you don't need to do health surveillance because they've got controls in place. Sometimes that's the case if you've got very high level controls, and we've seen the hierarchy of control earlier on. But certainly if you're relying on RPE as a control measure, then health surveillance may well still be required. So why do we do it? So early identification, so you can manage work-related ill health. For some conditions, if you remove the worker early or identify that they've developed a health condition early, that can mean a better prognosis for that condition. It also means you can review your risk assessments, both for that individual who's been affected, but also for the workers that are similarly exposed. So it's a way of feeding back into your risk assessments and your controls to say, hang on, are my controls adequate? No, they're not, because somebody's become ill. Therefore, what do I need to do to prevent further people becoming ill as a result of whatever they're exposed to in the workplace? So we've talked a bit about LEV and other aspects, but control measures may not always be reliable, despite checking, training and maintenance. So health surveillance is one of the other ways that you can start to identify if problems are occurring. And the act of undertaking health surveillance through occupational health professionals, we would normally have an opportunity to discuss any health issues that the worker has, if they've got any concerns, but it's also an opportunity to reinforce controls, training, make sure they do what they need to do, make sure they wear the RPE correctly, and so on and so forth. And you've kind of guessed now that perhaps that controls and health surveillance do fit together and they complement one another. So you've got your controls, which are fundamentally reducing the risk of exposure or preferably eliminating if you can, but certainly they should be adequately controlled. Health surveillance is the check for disease, and they work together as a cycle. The most frequent thing that we do see when I go out and support inspections is that the controls are put in place and they may or may not be adequate, but it's the health surveillance that gets missed off. I've not come across a place where they've only done health surveillance and the controls have just been left to rack and ruin. That's fortunately doesn't happen, but they are complementary systems and you do need both, and COSH does require that you undertake both where they're required. So, which leads me nicely into COSH. So the control of substances hazardous to health, which is clearly relevant in terms of thinking about welding fume exposures and the need to control the risks relating to that, but also to implement appropriate health surveillance. And I will, as I said earlier, talk a little bit about respiratory health surveillance in respect of welding fume exposures. But I also wanted to take this opportunity to remind you all about the potential need for health surveillance in other activities which may surround performing your welding activity. So we've talked a little bit about noise already. You may be using vibrating tools in your workplace environment. So there are two other areas that you need to think about, both in terms of control, but also the need for health surveillance, looking for vibration-related and noise-related disease respectively. Depending on other work you may do, you may be using lead, or you may go to workplaces where they're using lead, thinking about asbestos as well. And then just for completion, I know it's not particularly relevant in terms of welding activities. Sorry, I've just distracted, it wasn't appearing on the other screens, that's why I was just pausing slightly, is ionising radiation. So it's really just to point out there's a number of regulations that are present in statute where you do need to think about performing health or medical surveillance in order to comply with the law, but to protect the workers as well. So it's that broad brushed thinking which you need to think about in terms of your needs. So COSH is very helpful to us because it does give us quite a clear definition of when health surveillance is required. So there needs to be an identifiable disease or health effect linked to the workplace exposure, as you might expect. So we're thinking about the effect of work on the health of the worker, so we need to identify the disease that's present. It's likely to occur given the work being done. So I talked about earlier, if the process is completely enclosed, there's no risk of exposure, then there's no likelihood of the worker developing a workplace disease. Then you may be able to decide that health surveillance isn't relevant. But certainly for certain types of welding, you are going to need to look at health surveillance. It needs to be a valid technique, in other words, usually a medical test or a questionnaire, and the technique needs to be of low risk to the worker. So as you probably appreciate, there's lots of different medical tests out there, but if you are going to apply this to your workforce, it needs to be low risk to them and tolerable to them and acceptable as well in terms of what the tests involve. So thinking about how you set it up, so it is important that you get, particularly if you're not doing health surveillance already, that you do consult with your employees and their representatives. There can be a degree of suspicion about setting up health surveillance programs. People interpret it as a way of getting rid of them or looking the way at managing them out of the workplace. But it is important that consultation takes place so everybody understands why it's there, what you're going to do, and the possible outcomes. You also need to have a clear procedure on how you're going to manage cases of disease that have been identified. Quite often people will put in place a health surveillance system and happily go on through life. No cases have been identified, which is ideal, but then all of a sudden they get bitten by a case that comes along and they don't know what to do. So it's really important that's thought about up front. Then the final bit, which you can use health surveillance outcomes for, is use of grouped results. So if you've got workers who are performing a similar task in different parts of your workplace, some of them are developing disease and some of them aren't, you can look at the group results to start to say, well, why is this group developing problems, whereas the other group isn't? So it just gives you another way of trying to identify risks that aren't being controlled, and therefore you can do something about it. Oops. So, who does it? So the main message to get across here that I really want you to take home today is that health surveillance is performed by occupational health professionals. So you need somebody with adequate training and competency in order to provide you with health surveillance, to do any testing that's done correctly, and to interpret the results that are obtained and then feed that back to you. Sometimes we see that people are doing the tests and they are then getting a readout from a machine or the computer and they feed that back, but that doesn't involve a degree of interpretation. You can use responsible persons, and some people do use this in the workplace, and that's somebody who's trusted, who the workers can go to, and they may be involved in handing out questionnaires and so on and so forth. But those people still require training, and they need the support and access of the occupational health professionals in order to allow them to undertake that role. The final point is, and it kind of comes back to the point I was making earlier, you can't delegate clinical responsibility to non-medical staff. So in other words, if you're doing a test, it requires interpretation by an occupational health doctor or a nurse. It needs to be done by those people. It can't be done by an occupational health technician. So it's worthwhile asking when you're commissioning occupational health services how they access the occupational health nurse, the occupational health doctor, what qualifications and competencies they've got in terms of how they can provide a health surveillance service to you. And acting on the results, so you should get an output from the health surveillance. Sometimes we do see that falling down. So you should get an output of, is this person fit to work with the relevant hazard? So in this case, welding fume. If you're not getting something back, something's gone wrong, and as an employee, you do need to make sure the health surveillance system is working. And if you're not getting something back from your occupational health provider, you need to chase that up. You should also be told when further health surveillance is required. A lot of health surveillance is done annually when there's no problems, but if an individual is developing a problem or some other concerns, it may be that they need to be brought back sooner. So you need to be able to plan for that as well in terms of how that individual is managed. You need to act on the results. where workers are shown to have work-related disease, and there's a number of parts of COSH that talk to that in the regulation in terms of reviewing your risk assessment, reviewing your controls, looking at people that have been similarly exposed, checking for disease in those people, so that they then can manage the risks for the worker and who is affected and for any other workers that are involved. Now, the next couple of slides, I'm going to briefly touch on health and medical records because these cause quite a deal of confusion in terms of what they are, what they aren't, and who does what and who owns what. So a health record is required in statute, so COSH defines what a health record is required. It involves the individual's name, national insurance, the type of work they're doing, and the outcomes of health surveillance, and you need to keep that for 40 years. There are other regulations, such as the noise regulations, the vibration regulations, where there is no retention period, but you should keep them as long as the employee is employed. Some people keep them for longer in case there are other issues that may arise for claims and so on and so forth, but you need to do that in keeping with your own data protection systems. As I've said, it should include fitness for work. So is somebody fit with restrictions, or unfit for that particular role, and when the next review should be. And it shouldn't contain confidential medical information. So in other words, the details of tests, etc. The medical record is different, and this is not defined in health and safety law, and it's the record that's compiled by the occupational health professional. So in the case of looking at respiratory health surveillance, which we'll be talking about soon, it is the completed questionnaires, the data that it contains, the breathing test results, and so on. As I say, these records are not defined, the retention periods are not defined in health and safety legislation. So, but certainly they should be kept by the occupational health provider as long as they're providing the health surveillance services, and normally many people would keep them sort of 8 to 10 years after the worker has left. So that's more in keeping with medical record retention in terms of general data protection regulations, as opposed to it being defined in health and safety law. But some employers do choose to ask the records to be kept for longer in case there are any claims and so on, but that's an arrangement you need to come to with the occupational health provider. So I just wanted to touch on briefly about where health surveillance goes wrong. Perhaps not the best thing to do is talk about a negative, but it's a good way of demonstrating the pitfalls that we see in HSE, so it helps you to avoid those pitfalls going forwards. So the commonest thing that we see is straightforward and simple. The health surveillance is just not done. Now, most of the people where we go to where that is the case, it isn't done willfully or maliciously, it's just they didn't realise and the risk assessment is inadequate. So, but it is important to make sure that it is actually done. The next failing is where it is done and an occupational health provider is involved, but the test is performed incorrectly. So in other words, there's a technical issue, the machine's not calibrated, or whatever it is. The other thing is that serial results are not considered. So for many workers, they stay in the same job for long periods of time, and seeing trends in change of a particular test result can be very helpful in deciding whether or not a worker has developed a disease. And it's important that when you commission occupational health services, that they do consider serial results. But that brings me on to another point, is you may choose to change contracts periodically with your occupational health provider, which is completely at your decision. But one of the things I would encourage you to do is to make sure that the medical records follow the workers as you move between occupational health providers. Otherwise, the new provider loses the benefit of the previous occupational health test performed. The final thing is inadequate understanding of the workplace. So when you commission occupational health services, you can reasonably expect that they come to have a look at the workplace where you work, to look at your risk assessments, to have a look round, see the processes. If they don't do that, there's a good chance they won't understand what your risks are, how they're managed, and what advice they can provide you with. Quite often they can provide you with advice as they go around, say, hang on, this isn't quite right, you need to think about this, you need to think that, which helps you to protect your workers. But if the occupational health provider doesn't understand the work that you do, adequately, then you won't get adequate advice back. The next phase of where this goes wrong is the OH provider doesn't communicate the results. So in other words, they've done all the tests, you've commissioned the service, but they don't give you anything back. So it's really important that you chase it up. But we do from time to time have employers say, well, they didn't tell us anything, so we assumed it was okay. Actually, you as the employer need to chase it up to make sure you've got the results. And if you don't have the results, you have to assume the worker can't do that role until you get the results in front of you. And then finally, again, this does happen, unfortunately, relatively frequently in the scheme of things going wrong, is that everything is done correctly, it's commissioned correctly, the tests are done, you get the results, and then it's just filed in a drawer. And we do have a number of cases where, when we look back, we realise that this person was identified as having a disease quite a few years ago, it's been filed away, nobody's done anything with it, and therefore that disease has become worse. So it's really important that what you get back, you do look at it and you do take any actions as required. So this is just to flag up, we do on the website, HCGB website, we do have some guidance on health surveillance, and the web address is at the bottom there. That's just a screenshot of it. This gives you the broad brushes of how you approach health surveillance. It does link off to the various details, to the various different exposures you may have in your workplace, but it gives you what you have to think about, how do you manage the risk, how do you act on the results, so everything I've just covered in my slides. It also talks about occupational health provision, the different types of occupational health professional, what qualifications should be looking for, how they compare with one another, and hopefully that gives you some advice in terms of when you go to commission services, in the same way you go to commission any other competent advisor, you get what you need for the type of work that you're doing, and so you maximise the chances of doing everything as it needs to be done. So the final few slides of my talk today, I'm going to talk about occupational asthma, and David touched on this earlier. So in terms of occupational asthma as a general concept, we do have some guidance on our website in terms of how you approach health surveillance, and I haven't put the web link on there, but it's well known as G402. If you just type in G402 in HSE, you'll easily find it, and that's relatively recently been updated, and that forms part of our COSH Essentials series advice. So occupational asthma is asthma caused by a substance in the work environment. So where a worker is sensitised or allergic to that particular substance, further exposure, even at low levels, may trigger asthma attacks. If you detect symptoms early and modified a worker's risk, the risk of developing long-term asthma is reduced. So this goes back to the point I was making earlier. Some of the conditions we've talked about today are irreversible, but if you catch occupational asthma earlier, the chances are, there's a better chance rather, of you preventing that from becoming a permanent condition. And as you'll see from when you read G402, we do consider that stainless steel welding as to be one of the causes of occupational asthma, and therefore attracts the need for health surveillance. So thinking about stainless steel welding, so you've got chromium, you've got nickel, they're both sensitizers. You may also need to think, particularly if you're welding exotics, you may need to take advice around the metals that are in there, and whether you need to think about whether you need health surveillance as well. But I'm really just going to focus on stainless steel welding today and the need for health surveillance. So when do you need to perform respiratory health surveillance? So exposure to the main causes of occupational asthma or substances or processes where occupational asthma is a known problem. We know that to be an issue with stainless steel welding. Just for completeness, I've put in H334 as one of the labels related to occupational asthma. As I've touched on earlier, there's a reliance on PPE or RPE. The reason being is it doesn't fail to safe. So it may not be used correctly, we've already discussed that earlier, it may not be fitted correctly, and the amount of times we go into workplaces and people are either not being face fit tested or they swear blind they've been face fit tested, and many of the staff have got beards and they're wearing their tight fitting masks. And then the other the other reason to do it is a confirmed case of occupational asthma in your workers. In other words, you've already got a problem. So I've kind of touched on some of these parts already, but I don't think there's any harm in reiterating it. You need to get an occupational health professional who understands your business and risk. So I've talked about them going in, but you need to talk to them about, have they done health surveillance in other environments that involve welding? So in other words, they've got the skills, knowledge and experience to work in this particular space. Ideally, respiratory health should be assessed before exposure. And as I've talked about before, health surveillance is an ongoing series of checks. It's not just a one-off to say everything's fine. It's a series of checks over a period of time. And we do suggest that you do more frequent checks for new workers, in other words, newly exposed, to pick up any symptoms that may be developing earlier. And for respiratory health surveillance for occupational asthma, we do expect a respiratory questionnaire, or a standardised respiratory questionnaire, and a breathing test or spirometry. You also need a system in place for workers who develop symptoms before the next health surveillance. Now, it's conceivable that you could have health surveillance on day 1, the worker develops symptoms on day 2. You don't want to be waiting another 363 days before their next health surveillance to do something about it. You need to have a system in place which escalates that worker to occupational health so they can be assessed. So finally, just thinking about other aspects of your risk management system and other clues you may get to problems which are developing in a workplace. The workers may tell you. They may tell you there's a problem. They may tell you they're not happy. They may tell you they've got respiratory symptoms and so on. So it's making sure you look into that, take it seriously. The second thing is your sickness absence data. So if you've got workers going off and are going off with respiratory symptoms, it's whether or not that's related to your workplace. I used to be a general practitioner, and I didn't have any training in occupational medicine, and we've been trying to raise the awareness of occupational diseases in general practitioners. But don't assume that the GP would necessarily think about work-related diseases. Some GPs are very switched on. Some GPs have a diploma in occupational medicine, but not everybody will. So don't assume that the work-related element of disease will be picked up. And this can help you highlight cases of OA and issues with your working practices. So as a final slide, I'm just going to say health surveillance allows early identification of work-related ill health and help manage risk. You do need occupational health input as your competent advisor to provide you with health surveillance, and it's a complementary system to the system of control. So in other words, the two work together in order to manage your workplace risks. So I'll pause there. I think we're having questions at the end, and I'll pass on to the next speaker. So thank you for your time and listening to me today, and I wish you well for the rest of the conference.